Hi, I'm Laura Sokil. I'm a foot and ankle surgeon here at the University of Wisconsin, and today I'll be demonstrating a basic foot and ankle physical exam. The first physical exam portion I start with for the foot and ankle exam is gait. So I'll have patients come for a walk with me in the hallway. And it's important when you're examining their gait that you're getting vantage points of both them walking towards you and walking away from you. So you can see their alignment as they're walking towards you, and from their back as they're walking away from you. So as the patient walks away from me, I'm taking a look first, big picture, at the overall alignment, watching their hips, track over their knees, track over their feet. Then usually I have them walk towards and away from me a couple of times. The second time, I'll look maybe more closely at the foot and ankle and look at their hind foot, midfoot, and forefoot alignment as they're walking. Some pathologic states, if patients have a flat foot, you can see their arch collapse as they put weight on it. If patients have, for example, a tibialis anterior rupture, they may be borrowing the other extensor tendons or the toes to pull their foot up and clear the ground in swing phase. There's a lot you can gain from the gait portion of the exam. So the first thing to start with on the standing exam is an inspection of the skin and relevant anatomy. So I like to start with the patients first facing me head on with their feet pointed parallel. From this vantage, I can take a look at the forefoot and the midfoot alignment, in addition to taking a look at any sort of skin lesions or swelling, etc. The standing portion of this exam is really critical to get an understanding of patients' alignment and how their foot actually functions when they're loading it. This portion of the exam can't be duplicated with them sitting, so it really is critical to get them first standing. So if we go in order, you can start with the forefoot, take a look at the toes. For patients who have bunions or toe deformities such as crossover or hammer toe, we really get an idea of alignment standing. And then taking a look at the arch and seeing if the patients have a flatter arch like pes planus or a high arch like pes cavus. And then I'll have the patients turn around and face the opposite direction so I can take a look at their heel alignment. So again, it's important to have the toes pointed straight ahead and parallel, and then taking a look at the orientation of the heel relative to the leg. So if their heel tips out to the side this way, that's hind foot valgus out to the side. Or if the heel points inward this way, that's hind foot varus. Normal alignment is about 5 to 10 degrees of hind foot valgus. Deviations from that can be pathologic if they're symptomatic. For the remainder of the exam, we'll perform it with the patient sitting. Even though patients usually present for a concern on one side or the other, I always make sure I take a look at both feet. That gives me a sense of what their normal side may look like, and it gives me an opportunity to preview what the remainder of the exam will be on the contralateral, maybe more painful side, to give them a sense of what to expect when I get there. So for the next portion of the seated exam, I welcome the patients to place their foot on my knee. I think this gives me the best vantage point to see everything and allows them to relax and be comfortable while we're taking a look. So the first part of the exam, the skin or inspection portion, first from this viewpoint, I can take a look and I can see everything I need to see. The foot and ankle is unique in that there's not much of a soft tissue envelope around the relevant anatomy, so there's a lot that you can learn just by looking. So I go systematically. Usually I start proximally and I take a look at the big landmark. So this is the medial malleolus here on the inside. This is a tibialis anterior tendon here. And I look then distally through the midfoot and then through the forefoot, the toes, to take a look if there's any malalignment or if there's any wound concerns. Calluses are really relevant for foot and ankle alignment, so I take note of all of those. Relevant lateral structures, and we'll switch feet here to take a look, are the lateral malleolus, the sinus tarsi is in here, the lateral border of the foot, fifth metatarsal fractures are not uncommon. Going around to the back of the foot and ankle as well, the Achilles tendon is usually quite visible for patients. And I take a look to see if there's any swelling maybe that clues me in on a pain generator. Then I'll move on to sensation. So I think in terms of peripheral nerves first. The distribution of the sural nerve is the lateral hind foot. The superficial peroneal nerve crosses around the lateral portion of the ankle to the top of the foot and is the dorsum of the foot. The deep peroneal nerve travels in the anterior compartment and gives sensation to the first web space up in here. The tibial nerve travels around the back and gives sensation to the plantar aspect of the foot. And last but not least, the saphenous nerve gives sensation to the inside of the ankle here. When we think about dermatomes, the L3 dermatome is the distal medial leg, L4 is the distal lateral leg, L5 S1 is the lateral hindfoot, and S1 is more posterior leg and plantar foot. And next we'll take a look at pulses. The two peripheral pulses that you can palpate easily in the foot and ankle are first the dorsalis pedis pulse. This is on the dorsum of the foot between the first and second metatarsals and just lateral to the EHL tendon. So I take my hand and I gently place it on the top of the foot and I palpate for that pulse here. And then the second pulse is the posterior tibial pulse. This artery travels in the tarsal tunnel, which is posterior to the medial malleolus. So I start with my fingers behind the medial malleolus and I palpate for the pulse here. Sometimes this artery is a little bit deeper, so you may need to apply some gentle pressure to palpate it, but oftentimes it is quite easily palpable for patients. The next portion of the exam is motion, so we'll take a look joint by joint. Now, it's really important to have the patient sitting comfortably with their knee bent for this. If their knee is straight, that may limit your ability to fully assess the ankle range of motion. So we have our model here sitting with the leg dangling off the side of the bed and just relaxing. First, I'll examine ankle motion. Ankle motion is dorsiflexion and plantar flexion. So this would be ankle dorsiflexion, and this is ankle plantar flexion. Normal range of motion is about 10 or to 15 of ankle dorsiflexion and about 35 to 40 of plantar flexion. Then I'll look at subtalar joint motion, which is inversion this way and eversion this way. Normal range of motion is about 25 to 30 degrees of inversion and 5 to 10 degrees of eversion. Then, marching more distal, we'll take a look at the transverse tarsal joint range of motion. The transverse tarsal joint is a little complex, but I assess this in adduction and abduction. So I grasp the heel with one hand, and I grasp the forefoot with the other, and I move the forefoot side to side, and here you can see the abduction and adduction of the transverse tarsal joint. And then I go, last but not least, more distally, and I look at range of motion of all of the toes. Common condition of the big toe is big toe arthritis, or hallux rigidus we call it. Normal hallux range of motion is about 25 to 30 degrees of dorsiflexion to about 45 of plantar flexion. For patients with big toe arthritis, they may have less range of motion and be quite stiff. And then I take a look also at range of motion of all the lesser toes and dorsiflexion and plantar flexion as well. The next portion of the exam is motor. So thinking just as far as basic muscle groups and relevant anatomy, first we'll start with ankle plantar flexion, which is the posterior superficial and deep compartments. So I just grasp one hand to steady myself and put my other hand at the plantar aspect of the foot, and I ask the patients to push down. Sometimes I say like they're pushing on the gas pedal, so that's plantar flexion. Next, I'll ask the patients to pull up and pull their foot the opposite way. This shows me ankle dorsiflexion, which is the anterior compartment. Next, I'll show inversion strength, which is mostly the posterior tibial tendon and other muscles in the deep posterior group. In order to fully assess and truly assess the posterior tibial tendon, since that tendon is a plantar flexor and an inverter, I make sure to ask patients to point the foot down first and then push in against my hand. And you can see the posterior tibial tendon actually pops out back in here, and that really gives you a full assessment of the posterior tibial tendon strength. And then last but not least, I'll have the patients do resisted eversion, which is the lateral compartment. So I put one hand on the back of the ankle and another on the outside of the foot, lateral portion of the foot, and I ask them to push against my hand and evert the foot. Perfect. Next, we'll move on to doing some special tests for the foot and ankle. First, we'll start by checking the lateral ligaments of the ankle. There are 3 relevant lateral ligaments, but 2 that we can really stress well. The first is the ATFL, the anterior talofibular ligament. This runs from the fibula to the talus anteriorly. The calcaneofibular ligament is the next we can test. It runs from the fibula to the calcaneus more vertically. So to test the anterior talofibular ligament, I have the patient plantar flexed. I put one hand on the calcaneus and the front of the ankle here, and then my other hand is up on the distal leg to stabilize myself. I ask them to relax their ankle, and then I shuck the foot back and forth to check the ATFL. If there's any translation of the talus underneath the tibia, this will tell me the integrity of the ATFL. Then you can check the CFL with the foot in dorsiflexion. You can hold the foot dorsiflexed, so I still keep one hand here, another on the dorsiflexed foot. I ask the patient to relax as best as they can, and then I shuck the foot and ankle back and forth to see if there's any translation with the foot in dorsiflexion. The next special test we'll demonstrate is called the silver skull test. This examines calf flexibility, so whether the patients have contractures in either the Achilles tendon or the gastrocnemius tendon. So first I have the patient start with their knee straight, totally extended, and I dorsiflex the ankle as much as they'll let me. Then I tell the patients, let the knee bend and let the foot drop down. And this allows the gastrocnemius tendon to relax and come out of play. And so if we take the knee back straight again, you can imagine this is with both the gastrocnemius tendon and the Achilles tendon tight. With the knee bent, the gastrocnemius tendon relaxes and only the Achilles tendon is in play. So if patients have a change in the foot position with the knee bent, that means that there are contractures in the gastrocnemius tendon, while if the patients have some tightness with the knee flexed and extended, that means they have a contracture in the Achilles tendon. The next special test we'll do is to assess for Achilles ruptures. There's two very critical tests that we use, and I think it's really important for any clinician to know how to do these appropriately to fully assess for an Achilles rupture. So both of these exam maneuvers are with the patient prone, and I like to ask them to first bend the knee that's not injured on the side that's not injured. So I'll have you bend one knee up and bring the foot up. And this gives you a sense of their resting plantar flexion tension of the Achilles tendon. So then I'll have them bend up the injured side, so if you could bend the other side up, and I actually crouch down and I look side to side to see if their resting plantar flexion matches from side to side. You can imagine with an Achilles rupture, that side will have less resting tension of the Achilles tendon. The next important test to do is the Thompson test. So you squeeze the patient's calf and you should see the ankle plantar flex if the Achilles tendon is intact. If you do this test and squeeze the calf and they don't have plantar flexion of the ankle, then you're concerned that the Achilles tendon is ruptured. So in summary, that's a basic physical exam for the trainee. The beauty of the foot and ankle subspecialty is it can get pretty nuanced and pretty complicated quickly, but hopefully this exam gives you a good foundation to examine patients when you're on your orthopedics rotation. And I hope to see you around whenever you're on rotation. Feel free to reach out and we can chat more.